So welcome back to the Spartan Nurse Podcast. I'm your host, Dr. Mike Martell.
And I'm your co-host, Dr. Krista Reeves.
Today, please join us in welcoming Dr. Veronica Bernacchi on the show. Thank you for coming on today.
Thanks for having me.
To get us started, can you share with us a little bit more about your background and your role here in the College of Nursing?
Yes, I am an assistant professor in the tenure stream. My research focuses on identifying and ameliorating adverse social determinants of health that contribute to cancer disparities. And I'm a dog mom.
Oh, I love it. That's awesome. Can you tell us a little bit about your nursing journey? What inspired you to pursue a career in nursing, and what shaped your path along the way?
Yes, so I have a bit of a funny story about how I became a nurse. I actually got into art school the day before I decided to apply to nursing school. So growing up, I always thought I was going to be in the arts. And I was in a program in undergrad at James Madison University where you complete some of your core courses and then apply to whatever your specialty area is going to be, whatever your degree is going to be in. And I applied to art school, got the letter that I was accepted, and then the next day said, nope, I'm going to apply to nursing school.
Wow. That's such a change.
It is a big change. And I didn't realize it at the time, but even when I was applying to art school, I was already actually more interested in sciences. Part of my motivation for applying to art school was I wanted to develop these interventions to improve people's quality of life. And so I was thinking as a scientist, I just didn't know it.
Right.
But that day I got the letter, a friend needed to go to the hospital, and I took them, and I was sitting in the hospital texting my mom, saying, oh, it would be so cool to be a nurse. You'd be able to help so many people and learn so much. And my mom said, and you would look really cute in scrubs. So I applied to nursing school.
That sealed the deal.
That's great. That's awesome. So what were some defining moments or challenges in your nursing practice that motivated you to then explore higher education?
Yeah, so I had, I think, a bit of an interesting journey as a nurse. During undergrad, most of my clinicals were at local rural community hospitals. So I was very interested in the patient population I was seeing from the rural communities. And then after graduating, I went and worked at a large inner city academic teaching hospital where I did a nurse residency program. So I did that for a year and noticed that a lot of rural patients I had seen in clinicals in undergrad were traveling to this large inner city academic teaching hospital to get the care that they needed. Mm-hmm. And there I was on a gyne-onc floor. And so I started getting a little involved in policy work there, writing the nursing policies, EBP, evidence-based practice for the units. But I wasn't 100% sure where to go with that and how I could implement the most change. So I started looking for some different opportunities. And I ended up going to a different academic teaching hospital in DC, where I walked in and said, okay, I'm going to stay here until I make all of the changes I possibly can to improve things. And so I did a lot of different roles there. I was night shift charge for a couple of years, which is always exciting.
That's fun.
I was very engaged with committees at the hospital level, the practice committees, which would write the nursing policies, again, looking at evidence-based practice. And I did the same thing at the health system level. And so I thought that's where I was going, but I still wasn't making the changes I wanted to see. I was still seeing a lot of patients coming in right from our rural areas repeatedly. They were being rehospitalized. They were having the worst health outcomes. And I wasn't able to make the changes I wanted to see better outcomes for them.
When you decided to pursue a doctorate degree, what made you choose a PhD versus a DNP?
So I had no idea what a PhD really was in general, and especially not in nursing. I hadn't been exposed to it in undergrad, and I hadn't been exposed to PhD-trained nurses in the hospital systems. I worked with MSNs and DNPs in leadership, in writing nursing policy, evidence-based practice. And so when I started looking at graduate programs, I was looking at DNP programs. And I applied to a couple different DNP programs. And during one of the interviews, I was interviewing with a PhD trained nurse scientist. And she was talking to me and asked, well, what is it you want to be doing in 5 years? And I told her I had all of these questions. I didn't understand why the disparities I was seeing were happening. I wanted to understand the causes and the pathways of those causes. And then I wanted to minimize the disparities I saw. And she said, you can come here, but you're not in the right place. What you actually want is a PhD. I was like, oh gosh. So I started looking into the differences between DNPs and PhDs. And learned about how PhDs are research focused, where we are creating new knowledge, whereas for the DNP, it's practice focused, and they're taking existing knowledge and developing best practice. So evidence-based practice policies, a lot of what I had been doing already that I had decided wasn't quite the right fit. And so I ended up at the last minute turning down the DNP programs I had applied to, and I found a PhD program where I would be funded. And for anyone listening who's interested in a PhD program, there are so many different opportunities to be fully funded. You do not have to pay for your PhD. And I found one I'd be fully funded where my mentor was doing the work I was interested in doing, looking at rural cancer disparities. And it had access to a large academic teaching hospital, so all of the clinical resources that I was interested in for my research. So I decided to go get my PhD at the University of Virginia.
I love how, like, you talked about all of the things that you were doing, which was so aligned with the DNP. But then what you were really hoping to do was that a little bit of the next level as far as doing the research and trying to, improve patient outcomes and things like that. So that's interesting that, just the way that you looked at the two different programs, and they each have excellent value and they're both so needed. So I think that that's great for our listeners, because so many times they come to me and ask, okay, what's the difference between a DNP and a PhD? And I can give them my perspective, and then I'll send them over to Mike, and here's Mike's perspective with the DNP route. So it's interesting hearing it from a student, kind of how you're wrestling with those two options.
So how did your research training shape the direction of your work? Were there particular experiences or mentors that stood out?
So when I went to UVA, my dissertation chair, my advisor, was a nurse scientist who did a lot of work using the public health lens. And so she did a lot of interventional research looking at cancer disparities and rural-urban disparities especially. And so that aligned very well with my clinical background and my areas of interest. So working with her, I got a lot of exposure to some social determinants of health and cancer disparities, looking at telehealth as a way to improve access to healthcare. And then she kind of sent me into the public health department so I could take some courses there to get experience with community engagement, which led me to become very interested in qualitative methods because those methods are so pertinent to the early stages of community-based participatory research. And so I got a lot of training in qualitative methods, public health, social determinants of health, and those big training pieces I wanted to round out further in a postdoc. And so what I didn't have was training in epidemiology and a little bit more depth into public health, because most of my mentors had been nurse scientists. So for my postdoc, I went to Penn State, and I actually applied for a postdoc in the School of Medicine. With a mentor who was a cancer epidemiologist. So her background and training was all public health, and I went there. So all together, all of those experiences and methods kind of helped serve as the foundation for what ultimately became my research focus, and that is identifying and ameliorating adverse social determinants of health that contribute to cancer disparities.
So for those that are unfamiliar, How would you explain social determinants of health and their role in shaping health outcomes for our patients?
So I am a nurse scientist because I'm a nurse, but when I explain who I am and what I do, I actually say that I'm a health disparity scientist because that is what most of my training is in. And so what I do is I look at the etiology, so the cause of cancer disparities, the mechanistic pathways of those disparities. So very, very simply, if A happens, then B outcome happens. I want to identify that. I want to understand that. And then I look to develop and implement interventions that will reduce disparities. A health disparity is when we see a difference in a health outcome between the reference population. So for most research, that's going to be white men, but it depends on the research area, and a marginalized group. And we talk about marginalized groups. Those are populations who experience racism, discrimination, or they are underserved by our healthcare system. And then for the social determinant piece, social determinants of health are such a big buzzword that it's created a lot of confusion. So we have this thing now where we confuse a determinant of health with a social determinant of health. So a determinant of health is just anything that impacts a health outcome. And an example I like to use is if I am a woman, then I have increased risk of migraine. But being biologically female is not a social determinant of health. And so what a social determinant of health is that interactive process that we have with each other, with our environment, and with our resources. And so things like biological sex or race, anything that is genotype or phenotype, so your DNA or how your DNA is expressed, is not a social determinant of health. But being a woman, interacting with our social systems might reduce my access to healthcare. So women might be marginalized in terms of some healthcare outcomes. Same thing for those who identify with marginalized race or ethnicity, because of that, right? DNA, phenotype, genotype, they're interacting with our current cultural context, their environmental resources, they experience discrimination, they experience racism. And so the social determinant of health in these cases is discrimination, racism. It's not biological sex or race.
I think that is, I love the way that you broke that down.
I do. I love that.
Adding in the social piece and then talking about what is a determinant of health. What does a social determinant of health mean? I don't think I've ever had it broken down in that way. That was very nice.
I've worked very hard to come up with the clearest explanation I can. And so I think that gets a little bit confusing because when I talk about my research, I talk a lot about geographic disparities. And I think sometimes when we do that, people think, okay, well, geographic location can be a social determinant of health, right? We talk about rural like it's a social determinant of health. It's not. Geographic location, coordinates on a map, like that's not a social determinant of health because it has nothing to do with our engagement.
Right.
When we're talking about rurality, what we're actually talking about are the multiple adverse social determinants of health that are more prevalent in those areas.
Right.
So it's the low socioeconomic status. It's the poor access to healthcare. It's the fact that only 3% of mental health care professionals are in rural communities. 2% of oncologists are in rural communities. That's what we're talking about. The cultural community context, for example, with that. There's conflicting research on this, and I am in no way making a generalized statement, but we've seen in some studies that there are cultural norms that can reduce health-seeking behaviors for cancer. So, for example, fatalism. There's this idea in some rural communities that cancer is a death sentence, and so you don't bring the word up. And because of that mentality, people won't seek cancer screening. And so you can't go in there with an intervention and say, okay, I have a mobile lung cancer screening clinic. Everyone line up. I'm going to increase access to healthcare because of the cultural norms.
Right.
So
you have zero patients.
Right. You have to market it in a different way. And so to circle back to the main point there, geographic location is not a social determinant of health. When we talk about rurality, we're actually talking about the multi adverse social determinants occurring there.
So are there any specific examples you've encountered that highlight the connection between social determinants of health and patient outcomes?
Several. So the first research theme I have is the intersection of social determinants of health on cancer outcomes. So an example is I did a study where we looked at lung cancer risk, incidence, and mortality in counties that are both rural and persistent poverty. So we've already established that when we talk about rurality, we're actually talking about multiple adverse social determinants of health. And it's the same thing with persistent poverty. And for anyone who might not be familiar with that, a county that has persistent poverty is one where 20% or more of the population have lived below the poverty line, the federal poverty line, since 1980. And that also has multiple adverse social determinants of health. So we have systemic disinvestment, we have low socioeconomic status, we have certain cultural norms that we see there, we have poor access to health education. And so we were looking at some of the data on lung cancer outcomes, and we saw that in rural counties, lung cancer is 16%, mortality rates are 16% higher. That's right. And 16 to 20%, I don't remember off the top of my head. And then in persistent poverty counties, we saw a very similar trend where lung cancer mortality rates were between 16 and 20% higher compared to non-persistent poverty counties. And so what we did was we had this hypothesis that counties that were both rural and had persistent poverty would have the overall worst lung cancer risk, incidence, and mortality rates compared to all other county types. And so we did a secondary data analysis. And what that means is we took an existing national data set and we ran some statistics to test that hypothesis. And we found we were right. So lung cancer risk, which we measured as smoking incidence. So smoking, lung cancer incidence, and lung cancer mortality were highest in counties that were both rural and had persistent poverty compared to any other county type. And so that's an example of how multiple adverse social determinants of health contribute to the overall worst cancer outcomes, which I also hypothesize will extend to other chronic diseases.
Right. And then knowing that information, then you can take that and now what are we going to do about it? You know, what kind of interventions can we bring to this area, to this community, knowing their giant risk factor?
Right.
You know, and I'm thinking, this is something too, when we're teaching in the undergraduate program here in our classes, these are things that we can teach these future Spartan nurses, that these are these additional risk factors. I was preparing for our stroke lecture just the other day, and I noticed that there was updated guidelines for primary prevention of stroke, and social determinants of health was also coming up there as an additional risk factor that they hadn't really previously considered. It was those, standard risk factors, those modifiable risk factors, but nothing in that social determinants of health area. But I'm seeing that's great that that's a trend through those multiple, because that does have an impact on those outcomes.
It does. And I think a big takeaway from, this study, but also several other studies, is that we as clinicians need to assess social determinants of health. Right? We might see a note that says 45-year-old Black male admitted for chest pain. There's no social determinants of health in that. But then we might find out that they have low socioeconomic status and they're a family caregiver for their grandmother, and that they live in an area that has poor healthcare access because it's rural. And maybe it's also persistent poverty, because the vast majority of counties that are persistent poverty are also rural. And so they might be in a community with chronic disinvestment, and they might not have resources in their community. And we don't know that based on the notes we see from the patient, based on what we assess.
That's a really good point.
Yeah, got to dig deeper.
Yeah, absolutely. So telehealth has gained significant traction recently. How do you see telehealth reducing barriers to healthcare in rural areas?
So that's kind of the second big idea of my research, is after we've identified the areas that have adverse social determinants of health, right? What's the next step? How can we fix it? And so one strategy is to implement telehealth interventions, because we know that many rural communities and communities with persistent poverty might have poor access to healthcare services. So I'll give you all an example. When I was in graduate school, I was working with my mentor on a study where there was a nurse-led telehealth intervention for head and neck cancer patients after surgery, after treatment. And so we know that most patients who get their survivorship care plans, right, their discharge instructions, are going to forget that because they're overwhelmed and they're not able to process everything at that time. I mean, how could they be? This is such a major life event. And so we know that they're not able to process all of that information and remember it. Most say they don't even remember receiving the survivorship care plan. And so what this intervention was a way to deliver the survivorship care plan at a different time after the patients have gone home and had some time to recover, and to help with some of the post-treatment symptom management. So it was a live interactive video conferencing intervention with an oncology certified nurse. And what we found was that there were a lot of barriers to technology. First off,
that's what I was going to ask.
for our rural patients, right? There were issues with broadband. We know that lots of rural communities don't have broadband, and we had a creative way to overcome that, where we had a study iPad that had a preloaded cellular card on it. So even if they didn't have Wi-Fi, they had the iPad, they had the cellular data, they could connect. Well, then we found there was an issue with digital inclusion, right? They weren't used to having these
using the technology.
Exactly. And so that was the next issue. And we would have to have study team members drive out, set up the iPad so that they could talk to the nurse during for the intervention. But what was really interesting is as they were encountering these barriers to technology, we found they were very motivated to talk to the nurse because they wanted to engage in that therapeutic nurse-patient relationship, which is important because we have data saying that patients find the therapeutic nurse-patient relationship to be so critical in person at the bedside. Now we also know that they can establish it and that they value it when it is being delivered in a different platform, when they're engaging with nurses over live interactive video conferencing. And so we found that they were motivated to overcome barriers to technology in order to talk to the nurse. And as nurses, this might not be a huge surprise, but it's an important finding. We found that patients were willing to talk to the nurse about their psychosocial distress, and they weren't as willing to talk to other providers when we offered referrals. And so that has really important implications too, because we know that nurses are trusted over telehealth now, which means we might be able to improve referral uptake for social workers, for example, if we engage in warm handoffs, right? They trust the nurse, so the nurse can introduce this new person to the patient potentially. So telehealth has a lot of potential avenues to improve patient care by really leveraging that nurse-patient relationship.
That's great. I love that warm handoff. I love that. That's awesome.
Right, which there's research on for in-person, how great that is and important, but what if we also did it over telehealth? Yeah. So that's
cool
the next thing.
Yeah. Awesome.
How can the nurses better connect with and utilize the strengths of the communities they serve?
Well, first by knowing what the community strengths are. And so again, that's where the research piece kind of comes in. We recently were looking at a national data set that had information about social associations, so the number of social organizations, civics groups that are in a community. And based on some other research, I had this hypothesis that social associations might improve some of the cancer disparities in rural communities. So we looked at mammography screening outcomes. We know that patients who live in rural communities are less likely to be up to date with mammography screening. And so we found that is true. There was a 6% difference. So those living in rural counties were 6% less likely to be up to date with their mammography screening compared to those who live in urban counties, which is significant. Then we looked at social associations, and we found that if you lived in a rural community, there were 25% more social associations, so social groups, compared to urban communities, which is interesting and also not something I think you would expect, which probably has to do somewhat with the way that it was measured, but that is a different conversation. So the next thing we looked at was to see if social associations mitigated or reduced the disparities in mammography screening that we saw between rural and urban counties, and we found that it did. So if you live in a rural county with social associations and are engaged with those, then you're more likely to be up to date with your mammography screening. And so that's something that we can use moving forward, right? Nurses can leverage community resources, connect with local community leaders and organizations to get information out about mammography screening, about why it's important, and help kind of get more people up to date.
Mm-hmm. Finding those people that need to be connected, that need to be able to have that information, that are not in those, social networks, kind of targeting those people because they're the ones that need it the most.
Yeah.
Right?
So next we need to see kind of how that's working, right? We know that social associations are helping to kind of mitigate some of the rural-urban mammography disparities, but how is that happening? Is it because women are getting together in these groups, in social groups, and someone saying, well, I'm up to date with my mammography screening, so someone else is like, oh gosh, I'm going to do that
schedule
too.
that. Right.
Yeah.
Reminder.
Yeah, I'm going to do that too. Or is there something else that's happening? Is there a local healthcare provider who's at some of these organizations and they're sharing the word? So understanding that and then leveraging however it is happening so that we can hopefully eventually eliminate disparities.
And it'd be interesting too to know, this worked for mammography, but does it work for other things?
Right.
Does it work in different types of populations and different types of people in those rural settings? It'd just be interesting.
Right. And do we see the same thing in counties that also have persistent poverty? So a lot of different questions, and which happens in research, right? You test one hypothesis,
and then you're on to the next.
Then you have 20 more.
Right.
I know. And then just like listening to you, I'm like, oh, this is so interesting. I could just like study all these things. And I think that's one of the other pieces of being a PhD is everything is interesting, and you want to know more about every topic, but you have to limit.
You have to be very, you know a lot about a very little bit.
So we had some questions regarding practical applications for nursing that came in from our listeners. So the first question is, what advice would you give to health care providers that are working to address barriers to care in underserved populations?
I think a couple things. First off, to assess the adverse determinants of health in general, and then especially adverse social determinants of health that the community members in their catchment area, so in the area where their patient population is coming from, what they're experiencing. So assessing that, and then leveraging evidence-based practice, right? So looking at the research and seeing what we know. Okay, well, we have data saying telehealth is a great intervention to improve symptom management, to improve access to survivorship care plans. So is that an avenue that we can look at? Or should we partner with community stakeholders, community leaders, to get information out about mammography screening? So again, this is where that DMP, PhD collaboration is so important. And MSN too, right? We have CNSs and CNLs who are trained to look at the evidence and say, okay, well, based on what I'm seeing, there is a substantial support to change nursing practice policy and say, okay, we can do this nursing survivorship care via telehealth. We don't have to do it in person. So I think that just assessing the social determinants of health, looking at the literature to see what the most practical and most evidenced avenue for minimizing disparities are going to be.
So if you could offer one piece of advice to the next generation of nurses, what would it be?
So the one piece of advice I would give, and this is a little bit of one of my soapboxes, is that to remember that nurses deserve a seat at the table, and they deserve a seat at any table. So nurses should have a seat at the table when it comes to developing hospital policies. They should have a seat at the table when it comes to implementing best practice. And they should have a seat at the table when it comes to research. I cannot tell you how many times I have had someone say, oh, you can get a PhD in nursing?
I know.
And
Yes.
so there's so much research going on. There's research going on that has nurse in the name of the study, and there is not a nurse on the study.
Wow.
And so just remembering that you deserve to be there and kind of using your elbows to make that space for yourself when needed.
I think that's great. And then hopefully for future generations, when we create that elbow space, then it'll stay there and they don't have to do that because there will be an open seat at the table for our future generation.
It's so true. You know, I always remind our students, our Spartan nursing students, I always tell them, you know, because we teach in the undergraduate program, and I always say, you know, if you identify a performance improvement opportunity on the unit or quality improvement opportunity, it doesn't matter if you've been a nurse 6 months or 20 years. You can take the initiative and talk to your leaders, try to, you know, put a practice in place that will really have a big impact on a broad number of patients. And so, you know, you don't need to be limited. You know, patient care at the bedside is phenomenal, but if you identify an opportunity for improvement, you can take that and run with it. And really, I think that comes with empowering nurses and making them feel empowered that they can make that next step, and they can, you know, have a seat in the boardroom, and they can have a seat on these research projects. I think that's excellent.
And a lot of that is dismantling some of the historical perceptions of nurses, right? We have to look at the historical gender roles and social norms and things like that, and remember that we don't have to continue following those, right? Dismantle the establishment. Maybe cut that part. So the second thing is finding a mentor. No matter what path you end up going down, no matter where you are. I don't have words for how important mentorship is. I mean, someone who is able to give you guidance and see your strengths and help you identify your weaknesses, and, you know, round those out
your thinking.
too. Right. And someone who will support you when you say, oh, okay, I'm going to go apply for a PhD program, right? Or I'm going to go apply for a DMP program, whatever it is. Mentorship is just so important, and someone to normalize too, right? Being a nurse, and I think being a nurse today is so challenging. Someone to normalize the experiences that you're having and to bounce ideas off of. Someone you can say, okay, I just had this really bad shift. I don't know what to do, right? So
Thank you for joining us today as we interviewed Dr. Bernacchi.
Who will?
Spartan Nurse as well.